So guys, now let us start the class. Sorry for that technical glitch in between. I'm extremely sorry. So now let's continue the flow. Hi, hello everybody. Thanks for coming back here. Thank you so much. Chalo, now let's understand. So we were talking about the fracture healing and various factors which are responsible for healing, right? So such as your age, alcohol, diabetes, mellitus, smoking, steroids, and all patient factors, right? And the bone factors which include the if the bone is a open injury, so there are high chances of infection. Hence, it goes to delayed union or a non-union. Sometimes there would be soft tissue interposition, and sometimes the surgeons fault that proper reduction techniques were not used, or selection of the implants or proper immobilization protocols have not been used. So it may result in a complication of the union. There are three types of complications which can happen. There could be a delayed union, there could be a non-union, and there could be a malunion. So what is a malunion? So if you think this is the fracture fragment, so the fracture fragment has to unite like this, right? If the union is not aligned, so the union has something like this. So the union has happened something like this. So whenever the alignment, so this is called the alignment. So the longitudinal axis of the both of the fragments should be in the same line, right? But if you see, this axis is different, this axis is different. So this is called the malalignment of the fragments. That is nothing but your malunion, and this malunion can result in either a varus deformity or a valgus deformity depending upon that particular malalignment, right? Right. And then non-union. Non-union is nothing but there is no union at all. So this is the fracture fragment and this is the fracture fragment, and this has not united, so there is a lot of gap between them. So this is called the gap non-union. So this is called the gap non-union. So there are certain factors which are acting, that means the union is not happening between the fracture fragments. Here the union has happened, union is present but not aligned properly, right? So those are the complications of the fracture. So one is the delayed union. Delayed union means still you can wait for union to occur, right? So non-union, you need the surgeon's intervention. So that is the definition. So whenever you need surgeon intervention for union of the fragments, it is called as non-union. But still the union has not happened, but you can wait and watch, right, without any surgeon's intervention. That is called as delayed union. That is called as delayed union, right? So this is the definition of delayed union, non-union, and malunion. Hope you understood. So this is about the complications of your particular fracture healing, right? Yes. Now next we'll go to fat embolism syndrome. So now we have completed fracture and now we are dealing about fracture complications. So I'm going to teach you about three important complications here which are very important for your exams. The first one is the fat embolism syndrome. So coming to the fat embolism syndrome, so fat embolism is nothing but, why are we concerned about this fat embolism? Because you all know that the adult marrow is made up of fat, right? So whatever the marrow, whichever is present in the bone, is made up of fat. So this fat can escape sometimes, forming an emboli. So that is why this is called as a fat embolus. And now whenever this results in complication or systemic manifestation, then that is called as the fat embolism syndrome. So fat emboli can be present in multiple ways sometimes, but whenever there is the clinical signs and symptoms which is happening, then this will result in the fat embolism syndrome, which is very important and a very common complication expected in orthopedics. So where do you see this fat embolism syndrome? That is the first thing. So we will see in a long bone fracture, because the long bones have most amount of marrow, and typically the femur fracture is supposed to result in this fat embolism. So whenever there is femur fracture, tibia fracture, this will result in fat embolism. So there should be a long bone fracture. So only fracture result in fat embolisms? No. So this is trauma. Sometimes during surgeries, that is during fixations, whenever we are trying to fix the bones with the nails, we do a procedure which is called as reaming, right? So we are going to open the canal. So this is called the reaming technique. So we introduce certain instruments and we wide the canal so that we can put the nail inside. So while reaming or while opening that canal, while dealing with the marrow, sometimes the fat globules can escape and result in this fat embolism and can result in this fat embolism. So there are two things which can happen: the trauma directly, the fracture itself, and then the surgeries. So these two both can result in the fat embolism syndrome, right? So this is where the fat embolism usually occurs, right? And then what happens if there is a fat embolism? Why are we concerned about it? So this is the particular diagram I want you all to draw in the exam, so that you're not going to write anything. Just this diagram explains everything in detail. So here the first one is what I told you, the long bone fracture, and especially the femur fractures. And the second one here, what you're seeing, is the fracture fixation. So they are sending this nail through the femur, and I told you the process of reaming, if you can remember reaming, or whenever you're attending the orthopedic postings, you can ask the surgeon to show what is reaming. So these two techniques will result in release of these fat globules, right? So these fat globules will go into the circulation. They go into the circulation, and once they go into this venous circulation, they enter, and these can enter the lungs directly, or they can enter the systemic circulation. So whenever they enter the lungs, they damage the lungs, resulting in hypoxemia or hypoxia. So they result in hypoxia, and when they enter the systemic circulation, they mainly affect the brain, resulting in confusion. So they result in brain, that is confusion, and they result skin rashes, which are called as the petike. So these are the three important things which you have to look for calling this particular person as fat embolism syndrome. That is, one is hypoxia because of the lungs, the second one is the brain confusion, and the third one is petike. So this is the triad, the classical triad, where there is involvement of respiratory system, involvement of neurology system, and involvement of the skin. Okay, so this is the major criteria. And then the patient can also have this flat emboli, can also affect the kidneys, which will result in oliguria, right, or lipiduria, right? And in the liver, they might result in what is called as jaundice, and here retinal hemorrhages. They will have retinal hemorrhages, and they will result in fever, systemic manifestation, and heart, they might cause arrhythmias, and finally in the blood, they will cause thrombocytopenia or anemia, right? So these are all the manifestations of your fat embolism syndrome. So these are all the things which you observe. So what is the first important thing which we see? The first important thing what we see is hypoxia. So most of the patients, whenever they are manifesting this one, so first it usually happens 48 hours to 72 hours. So it usually, after the trauma, there is a gap for this to present. So that gap is nothing but about 48 hours to 72 hours. After that, the patient complains about shortness of breath. So first symptom what we see is shortness of breath. So usually up to 90% of the people present with shortness of breath, then up to 85% presents with confusion, and then up to 50% present with the rash. So these are the typical symptoms which we see, and then we see this list of symptoms as the patient presents with us. So these are little you can remember. So respiratory, I've told you there will be tachypnea, hypoxemia, and finally it presents as ARDS, right? Neurologically, I told you there will be confusion, but sometimes they're present with seizures. And dermatology is only petechial rash. Systemic, we have fever. And cardiovascular, I've told you there will be tachycardia, mainly tachycardia, arrhythmias, and finally they can end up with right side heart failure. And ophthalmic, we have discussed there will be retinal hemorrhages, or it is called as Pachas retinopathy, and renal oliguria, hepatic jaundice, and hematology is anemia and thrombocytopenia. And coagulopathy. Why coagulopathy? I'll tell you. So now these are the various symptoms of your fat embolism syndrome. And now let us understand what is the pathology of it. Why actually this is occurring? What is this fat embolism? So I have told you that this fat globules which are present, they escape into the blood vessels, right? And now they will initiate three important processes. So the first one is mechanical. The first one is mechanical theory. The second one is coagulation, right? And the third one is biochemical. So the first one I've told you, the mechanical. What is the mechanical theory? The mechanical theory is nothing but the fat causes the obstruction. It causes the obstruction, right? And then this obstruction will result in what? A inflammatory response, right? So whenever there is an obstruction to something, the blood can't flow through it, right? So then the body gets irritated, the capillaries get irritated, and then they will cause this fat embolism. And the second one is coagulation. So what is coagulation? Here what happens? Again, the whatever the fat globules, whatever are present, they will initiate the process of coagulation. So there will be coagulopathy. So again, it will cause obstruction. And what is biochemical? Here again, there is a process of inflammation where the lipase will act as a catalyst, and this will convert the fat into fatty acids. So there will be generation of toxic fatty acids. So there will be toxic free fatty acids which are generated, and this will cause increase in interleukin 6 and certain various inflammatory reactors such as your interleukin 1, interleukin 6, ECRP, ESR, and all this gets elevated. Finally, what will happen? So whenever, even if it is a mechanical obstruction or coagulopathy or inflammatory process by the free fatty acids, what will happen is there will be damage to the endothelium. So the capillaries endothelium will be damaged, and in the lungs the parenchyma gets damaged, and what ultimately happens is there will be VQ mismatch. So ventilation perfusion mismatch which will happen, and this will result in hypoxemia. This will result in hypoxemia. So there will be decreased blood level. So oxygen carrying capacity of the lung will get decreased, right? So that is why the patient will result in breathlessness, and then after this damage to the lungs, it will go to brain. It will create neurological manifestations or neurological symptoms, and then finally in the skin there will be petechial rashes, right? So this is all the pathology which is happening. So these are the three theories which you have to remember. So whenever you want to write the answer of fat embolism syndrome, first you will write the definition of the fat embolism syndrome. This is nothing but, it is nothing but a complication. It is an immediate complication of, or a early complication of, so this is an early complication, not immediate, early, because it's after a period of 48 to 72 hours. So this is an early complication of the fracture. And here what happens is the fat globules get escaped, and then they will result in certain symptoms. So these are the major symptoms. The respiratory, neurology, and the skin are affected, and there are other organs which are affected. So signs and symptoms. And then what is the pathology of it? The pathology, there are three theories behind it. One is mechanical, the coagulation, and the biochemical theory. And all this theory will result in damage to the endothelium or the capillaries, and then the parenchymal damage, which further results in the VQ mismatch, resulting in hypoxemia. Now, how do you diagnose it? So you know everything about the pathology, but once the patient is with you, how do you diagnose it? And this is done by Gurd's diagnostic criteria. I have told you again, the major criteria is nothing but petechial rash, hypoxemia, that is changes in the lung, and then your neurological changes, that is cerebral signs, right? And the minor criteria we have already discussed, that there will be tachycardia, there will be fever, there will be retinal hemorrhages, then there will be fat globules in the urine because the kidney is affected, and there will be sudden decrease in the hematocrit or platelet, that is anemia and thrombocytopenia, and they'll be raised in the ESR and the flat globules in the sputum. So these are all the signs and symptoms. These come under the minor criteria, right? So this is the major criteria and this is the minor criteria. So how do you diagnose it? Always there should be one major criteria plus 4 minor criteria will conform, and it is sufficient for diagnosis of your fat embolism, right? So now coming to the treatment, how do you treat it? So treatment of the fat embolism, first always you start with the heparin, that is anticoagulants. So you will treat with the anticoagulants, and because this is an inflammatory response, you go with the corticosteroids. So corticosteroids, and you can also treat with the oxygen, so high levels of oxygen, and then you can give something like glucose, hypertonic glucose. Okay, so these are the treatments. So it is usually symptomatic, but what is mainly important is they treat with corticosteroids and then they treat with the heparin, that is anticoagulants, right? So that is about your fat embolism syndrome. Is that clear? Yes, Pratik, hello. Abhinav, I don't think this is much useful to you. Yes, Abhyasachi, welcome back. Where are the others? Yeah, that is what is called the obstruction of the heart. So this cholesterol plaque that depends upon the position. So here what we are talking is about only small minute amount of flat globules, and now this might affect only a small part of circulation. But here what I'm talking about, the cholesterol is in the major arteries, right? Majors apply to the arteries. So that is very, very dangerous. That is why those are called the blocks. So if more than triple vessel block, if all the three vessels are blocked, then this will result in MI, right? That is myocardial infarction. The same thing. NEET UG aspirant or PG aspirant, Mad Max 1, 2, 3, 4, 5. Hi, Shiveha. Okay, now have you understood the fat embolism syndrome? Any doubts, guys? Okay, so now that is your fat embolism syndrome. Then coming to one more important complication, that is your compartment syndrome. So one more important complication and one more important question which they usually ask is your compartment syndrome. So what is a compartment syndrome? So before writing, you have to always start with writing the definition of what is compartment syndrome. As you know, the limbs, there are divided into osseofacial compartments. So the position, so the anatomy of the limbs, upper limb and the lower limb, are divided into the osseofacial compartments. Where, what do you mean by osseofacial compartments? That means there will be bones, and then these bones, they have fascia, right? And these bones are enclosed by the muscles, and these muscles are covered by the fascia. And also this fascia will divide them into compartments. For example, if you're taking the leg, the upper leg, so this is the up compartment. Now you can identify this as the tibia, this is the fibula, right? So this is the leg compartment I'm explaining. So this is the tibia and this is the fibula. And now you can see that this is divided into the anterior compartment, and this is your lateral compartment, and this completely is your posterior compartment, right? Again, the posterior compartment, you have the superficial posterior compartment and the deep posterior compartment. You understand? So this is how the muscles are placed in it. So these muscles are enclosed by a tight structure. Underline the word tight structure, which is called as the fascia. So here we are dealing with this osseofacial compartment, right? So whenever there is an increased pressure, because this is an enclosed space, enclosed space. So whenever there is an increase in volume, so here you have to go back your physics. So I'm telling you that there is a, if you see, this is the vessel here, this is a vessel here. So this is an enclosed vessel, right? It doesn't expand. Now what I'm putting a lot of water in it, and I've closed it. So what happens? The volume cannot expand because it is a tight structure. So, and you're putting more and more water. What happens? There will be no, so the volume is constant. So whenever the volume is constant, what happens? The pressure rises. If you remember, PV is equal to constant, right? PV is equal to constant. So whenever the volume is constant, what is the next important thing? It has to rise to compensate. So the pressure rises there. The pressure rises there. So whenever there is a rise in the pressure, so this increase in the pressure is called as the compartment syndrome. This is called the compartment syndrome. The basic of compartment syndrome what is the basic of the compartment syndrome? It is nothing but the rise in the compartment pressure. So there will be rise in the compartment pressure. And now you can ask me, what does this rise in the compartment pressure will do? Now for that, you have to understand that this particular pathophysiology. So here, come along with me. So now this is the any injury. So why actually this compartment syndrome occurs? So the most important cause of this compartment syndrome is trauma. So it is mainly the trauma, or sometimes it could be the surgery, and sometimes it could be burns, right? Or it could be some constriction around the arm, right? So constriction. So these are all the various causes. So fractures, surgery, crush injury, so any circumferential burns or any tight casting. So whenever you put casting very tightly, sometimes drug or fluid extravasation, sometimes position of the limbs, like in lithotomy. Sometimes in lithotomy you have to be very careful. This lithotomy position also will cause compartment syndromes, right? And electrical injuries, heat stroke. So these are the various causes which might result in compartment syndrome. But whatever might be the cause, there is a damage or injury to the compartment is through tissue ischemia. That means what happens? So here what happens is there is a some irritation. Okay, and because of this irritation there is a decrease in the blood supply. Ischemia is nothing but because of that irritation there is a decrease in the blood supply. So whenever there is a decrease in the blood supply, okay, so what happens is they will be resulting in the edema. So they will be resulting in the edema, right? So this is what is happening. So whenever there is edema, or whenever there is a fluid which is accumulating there, so they will be raised in the tissue pressure because of the decreased blood supply. And ischemia is nothing but decreased blood supply. Because of the decreased blood supply, what is the next thing? Inflammation, right? What is this inflammation? Inflammation is nothing but fluid accumulation, so that is nothing but edema. So whenever there is increased in the tissue pressure, again what will happen? There will be decreased in the venous hypertension. Okay, so what is this venous hypertension? If you go back and see the blood flow from artery, right, to particular organ, and from the organ to the venous, right? So this is how it happens. From the capillaries, again they connect and they go to venous, and from the venous they go to heart, they get purified, and from that again it will happen, right? So whenever there is venous hypertension, again there will be reduced perfusion pressure. Oh, almost always the blood flows from high pressure to the low pressure, right? So here what is happening? There is a raised pressure. So there is a raised pressure in the compartment. So because of this raised pressure, the blood is not flowing through the compartment. So that is why the perfusion has decreased. This decreased perfusion will again result in necrosis, right? So again ischemia is nothing but necrosis. So whenever there is necrosis, ischemia, inflammation, again edema. So this edema again will result in decreased pressure. So decreased pressure again will result in decreased perfusion pressure, right? Decreased perfusion pressure again will result in decreased blood flow. So that again will result in tissue ischemia. Understood? So whenever there is an injury, what will happen? This injury will result in damage Okay, so damage, you can tell this as inflammation or something. So this inflammation will result in what? It will result in edema. That means the fluid is not going into the artery, it is getting accumulated. So whenever there is fluid accumulation, there will be increase in the pressure, right? And now you remember, whenever there is an increase in pressure, so the perfusion, the word perfusion you have to remember. Perfusion is nothing but the blood flow is from artery. So artery to this particular compartment. But here, as the pressure is high, the perfusion, this blood flow is not able to reach the muscle, not able to reach that compartment. Again, because of this perfusion pressure or the blood flow is reduced, again there will be necrosis or ischemia. Again there will be ischemia. And this ischemia again will result in edema, right? Because there is again flow, there is raise in pressure. Because raise in pressure, again decrease in perfusion pressure. So this is nothing but, this is the vicious cycle which is happening inside the compartment, and this will result in the increase in the pressure further and further. Now what you have to do, the only thing what you can do is increase the volume. So you have to open the box, right? The pressure has been inbuilt so much that it might burst. Okay, so now you have to open up that box, right? So now this bursting is nothing but, if this is not opened at that time, what will happen? This will result in loss of muscles, right? So the muscles will undergo necrosis, and now they become into fibrous tissue. They become into fibrous tissue if it is not treated properly, if it is not treated properly, right? So this is the pathophysiology. These are the causes of the compartment syndrome, and this is actually the compartment, right? So compartment, causes of the compartment syndrome, and the pathophysiology of the compartment syndrome. Now what is the signs and symptoms? Now you know that there is a pressure which is building up in the compartment, and now the patient, how she will present to you. So this is an emergency, and now you need to diagnose it. You need to diagnose it, because sometimes there will be masks, right? So for example, if the patient is unconscious, if the patient is not able, if the pediatric patients not able to express properly, or if the patient is in epidural analgesia, all this will add up to the trauma, right? So the first and foremost symptom is the pain. So the patient usually presents with the pain, and then they will have paresthesias. So pain, paresthesias, pallor, not very important, paralysis at the last, and final one is your pulselessness. The final one is your pulselessness, right? The final one is your pulselessness. So these are the symptoms of the compartment syndrome. So these are the symptoms of the compartment syndrome. So very, very important, the symptoms. And finally, this pain can be confirmed by the stretch. If the patient is having the stretch pain, so if you're able to elicit this sign, that is the stretch pain. So usually in forearm, the flexors are one which gets affected, and now we are going to extend this like this, and now the patient is wincing with severe pain. That means it is a indication for us that you have to be suspicious about the compartment syndrome. So pain plus stretch pain is one thing which usually helps you for the diagnosis, right? And then you should always think about the analgesics as well. If the patient is having increased dose of analgesics, if the patient is having increased dose of analgesics also, you have to always think about the compartment syndrome. So remember, compartment syndrome is an emergency, and the clinical diagnosis is very, very important, because there is no such investigation which is helpful. So there is no investigation which is helpful, right? And one thing what you can do is, you can measure the compartment pressure. You can measure the compartment pressures by using the pressure transducers, right? So the pressure transducers can use, and the compartment pressure should be more than 30 mm of Hg. It should be more than 30 mm of Hg, or the difference is less than 30 mm of Hg. Difference between your diastolic arterial pressure, right? So your diastolic arterial pressure and your compartment pressure. If this is reduced, okay, so your diastolic pressure and your compartment pressure, the difference is, if the difference is less than 30 or the compartment pressure is itself more than 30 mm of Hg, then you can diagnose it as compartment syndrome, right? And now what is the management? So I have told you in the starting, the fascia which is very, very tight, which is not allowing the compartment to expand. So now what you do is, if it is a mild one, if you feel still, then you can go for limb elevation. So you can go for limb elevation, right? Not above the heart level, but at the level of the heart. So this elevation up to heart level you can still try. And then the ultimate treatment of this is fasciotomy. So you are cut opening the fascia. So surgical treatment is very, very important for compartment syndrome. So fasciotomy is the treatment. So what do the examiners expect from you when they ask you compartment syndrome? They expect you to write the anatomy of it. So first you have to know what is the anatomy of the limbs, right? So you're going to draw this particular diagram, a big circle, and then your two bones which are connected, and then your anterior compartment, your lateral compartment, and your posterior compartment, like this. Name the compartments, and then you're going to write what is a compartment syndrome. When there is an increased pressure, the following symptoms might occur. And this is the factor. These are the various causes which cause the compartment syndrome, and the pathophysiology of the compartment syndrome you're going to mention, and then what are the signs and symptoms. So this is very, very important. The signs and symptoms are very important. You have to mention them. And pain is a very important symptom. And then the sign is the stretch pain. So usually the most important thing is in the leg, the anterior compartment is most commonly involved, and in the forearm, it is the flexor compartment which is most commonly involved. So whenever your flexor compartment is involved, you're extending it, right? So that is called the stretch pain. And then the nerves get involved. So those are the paresthesias. And then because of the decreased blood supply, you can see a mild pallor there, and then the paralysis, and the final last one to occur is your pulselessness. And by the time the pulselessness is present, usually the limb will result in gangrene. So now there's nothing much to do if there is pulselessness, right? So you have to act at the pain level only, and then you have to do an emergency surgery which is called as the fasciotomy. So how will you do that fasciotomy? So this is the picture again telling you how to do the fasciotomy. You're going to open the complete limb, the 360 degrees. You have to complete fasciotomy you're going to do, right? Not only one compartment, all the three compartments you're going to open, right? And then you're going to check for any muscles which have been necrosed, and if there is there, then you will do what is called as the debridement. You can do what is called as the debridement, right? And then you will put the wound open only, no closure. Wound is open for at least 48 hours, and then you do a skin grafting, right? And then you close the wound with skin grafting, right? So this is how you treat them. That is fasciotomy. And all the compartments in the leg, it is like all the three compartments. In the hand, there are two compartments. So all the compartments should be open, and immediately no suturing. You have to leave them open at least for 1 or 2 days, and then you have to check for the muscle necrosis. You will debride all the muscle which have necrosed, and then you will close the wound either with the skin grafting or with the secondary suturing. Okay. Yes, that is about the compartment syndrome. Yes. Questions? Yeah. Yes, we have to cut the fascia to reduce the pressure. Sabyasachi, exactly. Even in snake bite, yes, we can see snake bite compartment syndrome. Very good. You can see snake bite compartment syndrome is seen also in the snake bite. That is venomous snake bite. Sometimes because of the toxins they release. Because of the toxins they relieve. Again, these toxins will result in edema, right? And this again, there will be rise in the pressure. Okay, now what is the sequel of this compartment syndrome? Now, what will happen if you don't treat the compartment syndrome? So, whenever they ask you about Volkmann's contracture, you always give a uh, starting words about compartment syndrome, because Volkmann's contracture is nothing but a complication of compartment syndrome, right? So this compartment syndrome, when not treated, what will happen? All the muscles which are present in the compartment will be converted into fibrous tissue. And if you remember, the muscles do flexion and extension, right? So they come, they contract and they relax, they contract and they relax. But this is not there with the fibrous tissue, hence they develop contractures. So this is called the contractures. This is like claw-like hand which is developed because of the because of the fibrous tissue which is formed inside, right? Yes, Sabyasachi, it is actually not guessing. It is actually you have developed the concept, because I have told you that the fascia is tight, and that is what is causing the what that is what was causing the closed compartment, right? So that is what subconsciously you are understanding the concept. Yes, atrophy of the muscles will result in fibrosis, not exactly atrophy. So conversion, so the muscle has been died, and now what whichever is dead, it will result in fibrous tissue, like so this fibrous tissue, the muscle completely is replaced by the fibrous tissue, right? And now this fibrous tissue a tight structure, right? Because if it is a tight structure, what will happen, it will pull like this, so it will pull all the fingers down. So here what you have to remember is, whenever they ask you the question about Volkmann's contracture, what you will write, this is nothing but a sequelae of either the compartment syndrome, or sometimes this is also due to brachial artery injury, which will again result in compartment syndrome only. So there is a brachial artery injury, usually in case of your supracondylar fracture humerus. So these are the questions or the answers which the examiner wants to listen or see in your paper. So whenever they ask Volkmann's contracture, you have to tell that this is a contracture. This is a fibrous contracture of the hand, right? Especially the upper limb claw-like position, right? It is claw-like deformity. It is a claw-like deformity of the upper limb which occurs either as a sequelae of the compartment syndrome or a brachial artery injury in case of supracondylar fracture. That is what you have to write. And then what you have to write, you will write the Oh, thank you so much. That's a very great words from Sabyasachi. So that is what you will So then you will write the claw-like deformity in the upper limb. This is either because of the compartment syndrome or the brachial artery injury in case of your supracondylar fracture humerus, right? And then what you will write. So here the pathophysiology. What happens in the Volkmann's contracture? So now the patient has developed compartment syndrome. You have not treated it properly. So the muscles have converted into the fibrous tissue. And I've already told you in the forearm, what happens is only the anterior compartment goes into compartment syndrome, mostly the anterior compartment. So because of this, the flexor digitorum profundus, is the muscle which usually undergoes fibrous tissue, which usually converts into fibrous tissue, hence pulling all the fingers like this. So hence it is like your claw hand. It is like the claw hand. So this is the pathophysiology which is happening. So then again the patient will have pain, he will have paresthesias, right? So they will present with pain, they will present with paresthesias. These two are very, very important, right? So they present in Volkmann's ischemic contracture also, they present with pain and they present with the paresthesias, right? And then there is a very important sign which is called as the Volkmann's sign. So this is expected. Again, this is what is expected from the examiner. So what is this Volkmann's sign? So this Volkmann sign is nothing but, so this claw hand which has been formed like this, and now what you see is whenever the wrist is extended, you see the clawing has increased. The clawing has increased because it is a fibrous tissue, right? You're making it more tighter. So it is becoming more clawing. Now you want to relax the fibrous tissue. So you're bending the wrist. So now the fibrous tissue is relaxing, and it is allowing the your fingers to extend. So this is your Volkmann sign. So this is your Volkmann sign. So what is a Volkmann sign? Now you're confirming it. This is because of the fibrous tissue. If it was a claw hand, whatever you do, wrist extension, flexion, the clawing will be there, right? But here, whenever you relax the wrist, the fingers get extended. So this is called your Volkmann sign. So this is called your Volkmann sign. So first thing, you will write the definition, then you will write the pathophysiology, then you will write the signs and symptoms, then this particular sign you will mention, which is called as the Volkmann sign. Now which is the most important thing here is the grades. So there is a grading of your Volkmann's ischemic contracture. So there is mild, there is moderate, and then there is severe. So this is what is again expected for you to answer. I mean, you have to write. So in this mild, what happens is only your FDP is affected. And here you can actually treat it with the dynamic physiotherapy or physical therapy, and your splints, and now it gets normal. So it is a limited Volkmann's ischemic contracture. Whereas in moderate what happened is even the flexor pollicis longus is also affected. So it is moderate type where you need surgery for it, right? So the name of the surgery, max page sliding operation. So this max page sliding surgery is what is recommended for this. And severe is very severe where all the flexors are involved and sometimes the extensors also. And then you can go for aggressive surgery, which include the bone surgeries as well. So this is just a soft tissue surgery for moderate, and for severe it is the bone surgery. So this is mild, moderate, and severe. And one more important thing which you have to remember is Volkmann's splint. So this is the Volkmann's splint. So now you see the position of the limb is maintained by this splint. So this is recommended for the mild variety. This is recommended for the mild variety, and this is again expected by your examiner. So these are the things which they usually look for. So whenever the question of Volkmann's ischemic contracture is being given, they will expect you to write the definition, including your compartment and your brachial artery injuries. Then they will expect you to write the pathophysiology. Then usually what they expect is the grades, and then your Volkmann sign, and then the treatment for it, right? So you can just draw a tabular form like this, and then you can write the types, right? So what are the symptoms of it and what is the surgery of it? So this will complete the answer, and you can directly write the mild, moderate, and severe. Write the symptoms here and then the surgeries or whatever the treatment is given in that block. So if you present is this way, it will be easy and it will be more fetching for you to gain more marks. Surgery to cut the fibrosis, yes, what actually happens is all the flexors, the common extensor origin. So what we do is there is a common origin for all the flexors, right? So we'll try to mobilize this. We'll try to mobilize this so that they can move. So you can easily move. It is not a tight structure here and here. So we try to mobilize it so that you can use the hand properly. And then what we do is we do the tendon transfers. Okay, so the muscles have been damaged, right? So these muscles will be replaced by the other muscles. So this is called the tendon transfers. And then we can do adheolysis. So we will cut the fibrous tissue, that is called the adheolysis. So these are the treatments or soft tissue procedures, the tendon transfers, the adheolysis. And when it comes to severe form, we go for bone resection. So we'll cut the limited amount of bone so that this will relax. So the fibrous tissue will relax. So that is for severe deformities. Okay. Yes, good. So that is about your Volkmann's ischemic contracture. So now we have completed the complications, and then little bit we will learn about the supracondylar fractures, right? So coming to the supracondylar fractures, this is very, very important, and it is very important in case of your pediatric fractures. So in supracondylar fracture, so now what is this fracture? Yes, I want you all to identify what type of fracture is this. Classify this fracture. Classify this fracture. Yes, very good. It is a displaced fracture. But before displaced or undisplaced, you have to name the bone. So I'll tell you, you have to have the S, B, C, D. So first, always look clinically, that is skin. Then comment on the bone, which bone you're talking. Then the configuration of the fracture, right? And then your stability, whether it is displaced or undisplaced, that one. Okay. So first, skin, you don't know whether this is an open or closed, right? So don't comment on it. Then go for bone. So you see this is a humerus bone, right? So we are dealing with the humerus bone, and that too the distal part of the humerus. And how is the configuration? It is a transverse fracture. And now it is a displaced transverse fracture, right? So this is how you should see. Complex. Simple and complex was very easy for everybody, right? Yes, you have to name this as a distal humerus transverse fracture. And now I tell you this is displaced. So what is this displaced? It is translation or rotation or angulated. What is this? So it is translated, right? It is translated. So this is a translated. Okay, now I tell you this is a closed fracture. I only told you this is a closed fracture. See, NEET aspirants, tell me whether it is NEET UG or NEET PG, what? Yeah, this is translation. This is translation. Very good. So that is how you have to comment. So now, whenever you're trying to answer a fracture, okay, whenever you're trying to answer this, so any fracture for that in the exam, especially for your prof exams, so always you will start with the definition of that particular fracture. So for example, if you are reading with the supracondylar fracture, then you will say it is an extra articular fracture. So you will say it is an extra articular fracture of the distal humerus, right? Of the distal humerus. Then you will say some important points about it. So for example, it is a most common fracture or what. So this is a most common fracture seen in children, right? So seen in children, most common, about like 4 to 8 years. So you will say this is most rare fracture or something like that. Some important points for each fractures. Then what you will write is, after definition, what you have to write is the displacements or the classifications. So now we have to tell about the displacements, or you have to classify the fractures. So the classification of the fractures, right? So that is nothing but your pathoanatomy. That means where the part is present, how the fragments are present. So that is the pathoanatomy. In that you will write about the classifications. Then you will tell the signs and symptoms of that particular fracture, right? And then finally you will tell the x-rays, how it appears in the x-rays, whether you have to take a AP view x-ray, a lateral view x-ray, or combination of both and all. And finally you will tell the management. So you will tell the management. So how you will do the management? So first, always you have to investigate again. So you will go for a CT scan or a MRI, confirm the diagnosis, and then you will tell the treatment. And then you will tell the treatment, and not to conclude without telling the complications. So complications is very, very important. So these are the side headings. So any fracture you have to write in this pattern. So first, definition of that particular fracture, pathoanatomy, in that you will write the classifications, then you will tell about the signs and symptoms, and then you comment about the x-rays, and then you will tell the management. In the management you have investigations and the treatment. Yes, and finally, always with the complication. So this is the pro forma, how you have to answer it. So here we have coming with the distal humerus supracondylar fracture. So whenever I say a supracondylar, that means it is above the condyle. So this means it is above condyles. and it is not involving the condyles, hence it is called an extra articular fracture. And be very, very specific, it is mostly seen in the age group of 4 to 8 years of age. So usually we see in 4 to 8 years of the age group, right? And now how the patient falls, the patient will fall with the extended, that is on the, it is also foosh, fall an outstretched hand. So they usually fall on this outstretched hand, right? And then they will have this uh, fractures, that is the supracondylar fractures. So once you witness the supracondylar fractures, so how the pathoanatomy goes, right? So here what is the pathoanatomy? So here what happens is the fracture is above the condyles, and usually it is a transverse fracture, right? It is a transverse fracture. And now this fracture has two types. One is flexion, other one is extension type. So because baby, that whatever the child falls in an outstretched hand, usually what happens is the extension type is most common. So there are two types in distal humerus fracture, that is supracondylar flexion type and the extension type. So the extension type is most common. This is what you have to remember. So that is the extension type. And now we have a classification which is called as the Gartland's classification system. So in this classification, we have types. So now you can see the types which are very, very easy for you. And now I'll tell you little bit of pathoanatomy. So here what happens is, this is your distal humerus, right? And now this is covered by a periosteum. Usually in kids, what is there? There will be a thickened periosteum. So the periosteum is very thick periosteum. So if this periosteum is intact, usually it is undisplaced. So because of the thick periosteum here, even though the fracture is there, it is an undisplaced fracture or a non-displaced fracture, which is type 1. And now this is an, what is this? Comment, what is this? This is a fracture with the angulation on the posterior aspect, right? Posteriorly, there is a hinge which is present. So this is a mild displacement with intact posterior cortex. And type 3, it is completely displaced. It is a complete displacement. And type 4 is an addition where there is complete loss of the periosteum, complete loss of periosteum, and it becomes more unstable. Okay, so that is why, see, we have learned the basics, right? We have understood what is displacement, undisplaced. Now it has become very easy for us, right? So the Gartland classification is for supracondylar fractures, and there are 4 types. Type 1, no, no, it is not a green stick fracture. Green stick fracture, there will not be any fracture in the opposite cortex. Here there is a fracture, but still the surface is in contact. In green stick fracture, the bend will be there. Here there is a fracture. Okay, don't get confused. And Sabyasachi, not always your guessing will be right. So to answer that question, you should have more. Now can you hear? Yes, I don't know what is happening on the YouTube. So, where are we? Okay, so now that is the importance of the Gartland classification, where you have to remember that it is type 1 non-displaced, type 2 is angulated with the posterior hinge or posterior cortex which is intact, and type 3 is completely displaced, right? And type 4 is it is an addition. So type 3, only Gartland has given three types. So type 4 is an addition. It is given by leech, which is given by leech, that is the complete loss of the periosteum, and hence it is not stable in both flexion and extension. Okay, that is it. And then once you complete the pathoanatomy of it, then you have to understand that this is the clinical presentation, the signs and symptoms, the signs and symptoms. So as soon as so signs and symptoms. So whenever there is a this case at the emergency, so what the first thing you have to do? The first thing you have to do is check the skin. So you can see that there is an ecchymosis of the skin, and because of the fracture there will be an S-shaped deformity which they present with the casualty. That is nothing but your swelling of the elbow, right? So whenever there is a swelling of the elbow with the S-shaped deformity, then you can see that it is a displaced fracture. Then you can say it is a displaced fracture, right? So it is a displaced fracture. And then the most important thing what you have to do is check for the pulses. You have to check for the pulses. So why pulses are very, very important? Because the radial artery, sorry, the brachial artery is at the brachial artery can be damaged in case of your supracondylar fractures. So why the brachial artery can be damaged? Now go back to the picture again. So if you see, this is a supracondylar fracture, and now you see this on the anteriorly you will find this brachial artery here. So this particular spike, whatever is there, can injure the brachial artery. So always you have to check for the radial pulsation. So you will check for the radial pulse. Okay. Pulses, that is the brachial artery, can be damaged. And then what you do, you also check for the nerves. So what are the nerves which can be damaged? So mainly the anterior interosseous nerve, then the median nerve, then the radial nerve, then the ulnar nerve. So this is the order. So based upon the displacements, again we know the displacements, right? The medial displacement, the lateral displacement, right? So mainly the anterior part. So the median nerve is in continuation with the brachial artery, right? So you both are nearby. So usually the anterior interosseous nerve followed by the median nerve, followed by the radial, and the ulnar will get damaged. So you have to check for the nerve. So these are all the things which you have to do in the ER itself. So first check the skin, then the deformity, then the pulses, and the neurological status. So if everything is fine, then you will go for the X-ray. So then you will go for the X-ray, right? So X-ray, how you're going to take? You will take an AP view and a lateral view. Which is more important here? The more important one is your lateral view. So the more important one is your lateral view. So what you're going to see on the lateral view is this. So sometimes even the undisplaced fracture we need to diagnose, right? So if you see this particular picture here, this is the anterior humeral line. So this is the anterior humeral line which I am drawing on the anterior part of the humerus on the lateral X-ray. So this is the lateral view, right? So lateral X-ray, and this anterior humeral line should cross the capitulum. So this is the anterior humeral line, and it should cut the capitulum in any direction you put the limb. So it is not like only you put 90 degrees of flexion, even 30, 20, 10 also. Any degrees of flexion, it will cross the capitulum, or else at least it should touch the capitulum in case of your undisplaced fracture. So this is completely normal, and here you see it is not crossing the capitulum. That means it is completely displaced. So this is the anterior humeral line, which is very, very important. And one more important thing which you have to remember is the fat pad sign. So fat pad sign is nothing but the accumulation of the fluid will present as the fat pads both on the anterior and the posterior. Anterior and the posterior. But anterior usually we are not much bothered because normally also it can be present, but posterior is very very important. If the posterior fat pad sign is positive, which is also called as the sales sign, so that is nothing but you can see that this particular fluid which is accumulating is causing a darker shade. So you can see that it's a little darker compared to the this part and this part. So you can observe that lucency there. So that is the fat pad sign. So anteriorly also it is present, but this is not of much significance. But if the posterior fat pad sign is present, that means it is an undisplaced fracture. So these two are very important in case of the supracondylar fracture humerus x-rays. So this is the ecchymosis. This is the X-ray on the AP view, and this is your S-shaped deformity. On the lateral view, you will comment upon the anterior humeral line crossing the capitulum and the fat pad signs. So these are all about the X-rays. So once you confirm the diagnosis of it, and then you will go for the management. So how do you manage a case of supracondylar fracture humerus? So this case I'm talking when the pulses are present, right? So whenever the pulses are present, what you do is the most important thing, you have to reduce the fracture. Reduction is very very important. So how do you reduce it? So first you give a traction which is a longitudinal traction. So this longitudinal traction on both the sides in extension, you will push this, the surgeon will hold the hand and pull, and the assistant will hold the hand here, right? This arm you will hold it, and this hand, and you will pull it in the traction, that is a longitudinal traction, right? And then after the traction you will correct it, and once the traction is corrected, then you will flex the limb, and then you will push the olecranon and reduce the fracture. Okay, 3 points which you have to remember. So first you're going to give the traction longitudinally, then you're trying to flex the limb like this, and then you will put force on the olecranon. So this is the olecranon, so you will put your thumb on the olecranon and you push it forward. So one of it is like, imagine that this is the fracture. Once you will pull that, so these two will fall in one place, right? Once they fall in the place, they have to get locked. So that is why you put your thumb on the olecranon and push it forward. So the posterior fragment, whatever is there, this fragment, this posterior fragment, whatever is there, you will push this forward. So now this will get engaged. So once they are engaged, how we will maintain the reduction? The reduction is maintained by K wires, percutaneous K wire fixation. So you will maintain it by percutaneous K wire fixation, right? You will do a percutaneous K wire fixation. So this is your percutaneous K wire. So you're sending, so now we are reducing it properly, and then you will put it with the K wire. So once the K wires are done, then you will put a slab and secure it for 3 weeks. So why 3 weeks? Why 3 weeks? 3 weeks for the fracture to become sticky, right? The soft callus is formed at 3 weeks, and after 3 weeks you can slightly mobilize the fracture. So that is the treatment and the management. And once, if the patient is having absent pulse also, you will first give the traction, and then you should be sure if it is pink. So you will see the capillary filling here. So if the pulses are absent, you will rely on capillary filling. If pulse is absent and still the hand is pink, that means there is perfusion which is present. Then you will again go for a reduction and fixation. And again you will check for the pulses. If the pulses are present, then you will go for, then you can tell the patient happily that the pulses have been revised. And if there is an inadequate perfusion, but still that pulses are absent, but the hand is not pink, that means there is no perfusion, right? Then you will go for exploration and repair. You will go for exploration and repair. So what you have to remember is, pulse is absent, then you will depend on whether the perfusion is present or absent. So how you will know the perfusion is present or not? Depending upon the pink color of the hand. If the hand is pink, if the hand is pink, forget all this. Just follow this. So now I'm telling you, so there is no pulse. So there is no pulse. First of all, there is no pulse. The pulse is absent. But still you give traction and reduce it with elbow flexion. And now then you will check. So now you will check if it is a pink color hand. That means perfusion is present. So if the perfusion is present, what you do? You will just reduce it and you will fix it again with the KYS. If the perfusion is still present, if the perfusion is still there, you will admit the patient and you will put for observation. But if the perfusion is not there, that means after giving traction also, if the hand is not pink, then you can go for vascular exploration and the repair. If the perfusion is not there, if there is no perfusion, then you will go for vascular exploration and repair. See, the ultimate idea of this is you will not open it. So usually what they will do is they will close reduction. We do a close reduction. That means we are not going to open the fracture and reduce it. We are doing maneuvers from the outside, right? So whenever the pulses are not there, we can feel that, you know, the brachial artery got trapped and we are trying to open it. So you should not try to open the fracture. What you have to do is you should rely on the perfusion, not on the pulses. So if the pulse is absent and the hand is still pink in color, that means the perfusion is present. That means the perfusion is still present and you can still go for percutaneous pinning. That means you will reduce the fracture and fix it. If after traction and reduction, if the pink color is not there, then you can go for vascular exploration and repair. That's it. So for that, you can draw this beautiful diagram and then you can score good marks in the exam. Now, what is most important here? The complications. So the complications here, the first one is, I told you, the early complication, that is the brachial artery injury. So the vessel gets injured. That is the early complication. Then the nerve can get damaged. Again, AMRU, which you remember, right? So then you can have the early complications. So these two can be considered as the immediate complications, right? So these two are the immediate complications. And then we have the early complications where you can have the compartment syndrome, right? Compartment syndrome is the one which you can have here, and the late complications. So the late complications are very, very important. One is the malunion. So what is malunion? The fractures have been not aligned properly, so they will result in malunion, and this is called as the cubitus varus deformity. So this is your malunion I was telling you. So if you draw a longitudinal axis like this and one is like this, so this is not aligned. Usually it should be like this, right? So here you see there is some degree which is not aligned, so that is called as malunion. And because the distal fragment is towards the medial side, it is the cubitus varus malunion, which is also called as the gun stock deformity. So the treatment of any malunions is osteotomy. You have to cut the bone and align it again. So you will do osteotomy for your gunstock deformity. And then one more important late complication is VIC. We have discussed it in detail. Whenever there is a brachial artery injury or the compartment syndrome, the late complication it can result is your VIC. That is Volkmann's ischemic contracture. So these are certain complications which are associated with your supracondylar fracture. So early, immediate, early and late, right? So immediate is your brachial artery injury or your nerve damages. The early is your compartment syndrome which can occur, and the late one is your malunion, that is the cubitus varus or gunstock deformity, and your Volkmann's ischemic contracture. So these are the late complications. So any fracture you should always end with the late complications and its management. Okay. Yes. So that completes your supracondylar fracture humerus, and then comes the lateral condylar fracture. So lateral condylar fracture. So talking about the supracondylar, I told you this is an extra articular fracture, right? So this is an extra articular fracture, right? But when it comes to lateral condylar fracture, it is an intra articular fracture. So this is an intra articular fracture, right? So when it is called as an intra articular fracture, That means it is involving the joint. So the joint is involved. So the elbow joint is also involved in it. Right? So in the lateral condylar fracture, we again have the classification. If you remember, this lateral condyle is nothing but it is a common extensor origin, right? Right? So this is the classification. So if the attachment to it, and if it is not extending into the joint, only the extra articular part is involved, it is type 1. But if it is involving the joint partly, it is type 2. And here the fragment is completely rotated because of the pull of the common extensor origin, that is type 3. So this is the classification of the lateral condyle. But what Milch, you have to remember the classification name here, it is Milch. So here what Milch has told is here in type 1 what is involved is, and again going back to the lateral condyle, it is again more common in the pediatric population, and if you see this is involving the physis. So what do you mean by physis? Physis is involvement of the growth plate. So physis is nothing but there is an involvement of the growth plate. So whenever there is an involvement in the growth plate, you will see that the Salter-Harris classification will come into the play. Right? So coming to the Milch here, what you have to think here, you see this is the metaphysis and this is your epiphysis, right? So here what is happening is a small amount of the meta and the epiphysis has been damaged here in case of Milch type 1. And here if you see it is a larger fragment which is going through the physis. So metaphysis, physis and epiphysis, right? That is Milch type 2. Okay. Now so here the type 1, this can be Salter-Harris of type 2 and this is type 4. So now for that you have to understand what is Salter-Harris classification, right? So just for now you remember that the lateral condylar fracture, it is an intra-articular fracture, and here what happens is there is an involvement of the